Fat embolism, FE, occurs when fat droplets enter the bloodstream and travel to distant organs. Fat embolism syndrome, FEs, is the clinical manifestation of FE, presenting with a petechial rash, cognitive impairment, and respiratory distress, usually within 24 hours post-injury. Autopsy studies reveal that about 90% of skeletal trauma cases have microfat droplets in the pulmonary vessels, though most cases are asymptomatic. Differentiating clinically significant FEs from asymptomatic fat embolism is important for diagnosis and management. Gauss categorized FEs into 3 clinical types in 1924-1. Pulmonary type mimics pulmonary embolism with symptoms like dyspnea and hypoxemia. 2. Cardiac type microvascular coronary embolization causing hypotension, dyspnea, and tachycardia. 3. Neurologic type cerebral embolism presenting as cognitive impairment, confusion, or coma. The prevalence of FEs varies across studies, with lower rates in retrospective studies, e.g., 0.26% to 0.9%, and higher rates in prospective studies, 11% to 13%, while specialized tests show systemic fat emboli in up to 87% of cases, though clinically significant FEs is less common. The risk factors are demographics. FEs is 4 times more common in males and primarily affects those aged 10 to 39 due to differences in bone marrow composition. Age-related prevalence. FEs incidence is lower in older patients, particularly those with low-energy hip fractures. Trauma-related risks. Hypovolemia after trauma increases inflammation and platelet activation, raising the risk of fat emboli adherence. Fracture type. High-energy trauma and long bone fractures, except femoral neck, have the highest risk. Closed fractures are riskier than open fractures. Surgical factors. Delayed fracture fixation and closed reduction increase the risk of FEs. Operative techniques. Reaming during fixation increases fat emboli dispersion. Unreamed nailing reduces this risk. The presentation. Respiratory. Dyspnea, 75%. Hypoxemia, 90%, may progress to respiratory failure or ARDS, with mechanical ventilation needed in severe cases. Neurological. Cognitive impairment, seizures, and possible loss of consciousness, cerebral edema and rare spinal cord infarction can occur. Cardiovascular. Hypotension, pulmonary hypertension, and potential for rapid collapse due to right heart failure. Dermatological. Petechial rash on the chest, neck, and mucosa, resolving within 24 hours. Retinal. Blurred vision, scotomus, Hirsch's retinopathy, often due to retinal ischemia. Laboratory. Anemia and thrombocytopenia are common findings. The pathophysiology of fat embolism syndrome, FEs, involves 2 main hypotheses, the mechanical and biochemical theories, which may work together. Mechanical theory. Proposed by Gauss in 1924, this theory suggests that trauma or surgery disrupts fat in bone marrow, allowing fat droplets to enter the bloodstream. These fat emboli travel to the lungs, blocking small blood vessels, causing tissue damage, inflammation, and clots. Larger fat droplets can block major vessels, leading to right heart failure and shock, while smaller droplets can reach the brain, causing neurological symptoms. Some possible mechanisms for bypassing the lungs include passing through a patent foramen oval, small hole in the heart, or pulmonary bronchial shunts. Biochemical theory focuses on the inflammatory response triggered by fat emboli. Fat is converted to free fatty acids by lipase, causing inflammation, swelling, and bleeding in the lungs. Pro-inflammatory substances like TNF-alpha and Illinois-6 promote clots and further damage the lungs, similar to ARDS, acute respiratory distress syndrome. This theory also explains FEs in non-traumatic cases like liver disease, sepsis, or pancreatitis due to increased free fatty acids. The diagnostic criteria are 1. Diagnosis of FEs. There is no single test for FEs. Diagnosis is made by excluding other causes through clinical, biochemical, and radiological assessments. 2. Diagnostic criteria. Gird's criteria, 1970, requires 2 major or 1 major and 4 minor symptoms. Major, respiratory distress, neurological symptoms, petechial rash. Minor, fat in urine, jaundice, fever, tachycardia, anemia. Lindex criteria includes arterial blood gas analysis. Schoenfeld's system uses a weighted score. 3. Laboratory studies. Common findings include thrombocytopenia, anemia, hypocalcemia, and elevated inflammatory markers, e.g., IL-6, but no single test confirms FEs. 4. Imaging studies. Lung X-rays may show bilateral opacities, while high-resolution CT can reveal a crazy paving pattern. Brain imaging with diffusion-weighted MRI shows a starfield pattern of lesions. Transcranial Doppler detects microemboli. Management of fat embolism syndrome. Early fixation. Early fracture fixation reduces FE's risk, while delayed fixation worsens outcomes. Orthopedic procedures. External plate fixation preferred. Unreamed nails and careful reaming reduce fat emboli risk. Pharmacologic. Corticosteroids help reduce FE's risk. Heparin, aspirin, and statins have potential but lack robust evidence. Supportive care. Fluid resuscitation, vasodilators, ECMO for severe cases. Monitoring. Continuous respiratory and cardiovascular monitoring, with pulse oximetry and echocardiography during surgery. Respiratory management. CPAP or mechanical ventilation for hypoxemia, treat like ARDS. Right heart failure. Maintain right heart pressure, use vasodilators if needed. Cerebral dysfunction. Monitor ICP, maintain cerebral perfusion, MRI useful for prognosis. Prognosis. 10 to 44% require ventilation, mortality approximately 10%, with most neurological symptoms resolving favorably.